We shall be continuing with R.A.T.S, Racing Against Time for Students in Pathology, and the chapter is GIT. The topic for the day is Polyps of Intestine. This can be asked as an essay, a short essay, a multiple choice question, viva voce, or come in the practicals of both pathology as well as surgery. Think of the subheadings. The subheadings will take you to the answer. And these are the panel of subheadings that we should have in mind. This incidentally is a picture of a polyp. Have it in mind. We shall be repeatedly seeing it. Definition. A polyp is a lesion that projects above the surface. It can be either the mucosa or the skin. And these are the ways of classifying the polyps. It might be solitary or multiple, pedunculated or sessile, true or pseudo, neoplastic or non-neoplastic, sporadic or part of a syndrome. So this is a very nice and logical way of dividing them. And look at this picture over here. This is a sessile polyp. In the sense, it doesn't have a stalk. It is flatly adherent to the surface of the mucosa. And its counterpart over here is pedunculated. A long stalk is over here, and this is the polypoid lesion that we are seeing. As mentioned earlier, it can be solitary, but look at this particular picture and count the number of polyps that we have got. You find that there are innumerable, say at least 100 polyps in this particular one, and the patient can be having more than 1000 polyps in the intestine. A minimal of 100 is a criteria for familial polyposis. By heart, this list. There are a lot of syndromes that are associated with it. We shall be dealing with them later on. So this again is a picture. Try to draw this one and describe it in detail. This is a fantastic line diagram, very easy for the students, a must draw picture. So this is the normal mucosa and this is a muscular layer. I find that the lesion is limited to the mucosa, and I'm finding the normal mucosa going along the stalk for some time, after which it proliferates into a polyp. And sometimes there can be normal intestinal folds which are thrown. So this is a normal intestinal fold and this is a polyp. So this is the stalk of the polyp, which will be having a fibrovascular core, and this is the polypoid lesion as such. A definite draw for the students. This is a schematic picture which will just give us an idea of the range of polyps. A normal mucosa is over here, and when the normal mucosa proliferates, we call it a hyperplastic. Hyper means more, plasia means proliferation. So it is a hyperplastic polyp, and usually it has got a serrated edge that again we shall be seeing. Look at this particular polyp over here. This pink line is the muscular tissue, and it also goes into the polyp. It branches and rebranches. This is a peculiarity of a polyp called the Peutz-Jeghers polyp. And in some cases, I find well punched out glands. It is very common in a juvenile polyp, which is a hamartoma. Hamartoma means it is an abnormal proliferation of a normal tissue. And villus polyp, villi all of us know, finger-like projections are there, and it is sessile, flatly adherent to the surface. Pseudopolyps are some lesions which are being projected up when we put in an endoscope. But actually, it is not a proliferation of the mucosa, but something from below is pushing it up. It can be a lymph node or it can be some other tumor, such as a carcinoid, which is projecting the mucosa. And pseudopolyps, these are called as pseudopolyps. And a carcinoma as such, obviously, one word is infiltration. So sometimes even a malignancy can be having a polypoid picture. Familial adenomatous polyp. More than 100 polyps are there. It is an autosomal dominant condition. And we had earlier seen in the topic on colonic carcinoma, there is an APC gene mutation. Adenomatous polyposis colon gene mutation. And the type of adenoma that we get is a tubular adenoma. Since there are multiple, it is not possible for us to surgically remove it. And even if we do remove them meticulously, another one will sprout out. And there is a 100% chance of a malignant transformation. This can be asked as a ultra short question, but please have it in mind. More than 100 polyps, adenomatous, autosomal dominant, and then it is a adenomatous polyp with 100% malignant transformation. A hyperplastic polyp, as I mentioned earlier, plasia means proliferation. Here, the mucosal glands are multiplied. So I find numerous glands over here, and it is the most common polyp. Overall, for all the polyps, neoplastic, non-neoplastic, everything put together, this is most common, occurs in the age of 60 to 70 years. It is predominantly sessile, no stalk is there. And when we come to the individual glands, look at the lumen. I find that the lumen is somewhat irregular. We call it as serrated or sawtooth. This yellow arrow points out to the lumen. Numerous glands, serrated lumen. And it is a hyperplasia, not a true tumor. This is the Peutz-Jeghers syndrome that we had mentioned earlier. And what is the meaning of a syndrome? It is a group of disorders, of which I find that the polyp is one. There is a huge polyp that is there, and there is this pink line that we are seeing is a branching muscular core. Usually it is only fibrovascular, but here I find the smooth muscle itself is branching and supporting the glands. The patient otherwise has got pigmentation of the mucosa. It's a Peutz-Jeghers syndrome. Sometimes it can be associated with malignancies of other visceral organs. And the typical appearance is a pine tree-like appearance. So the muscular core, it branches and rebranches just like a pine tree. Adenomatous polyp. Adenoma means it is a benign counterpart of an adenocarcinoma. It's a benign tumor. There are three types of this adenoma. One is a tubular adenoma, another is tubulovillous, third one is villous. So in this one I am finding, just like the earlier diagram, I find that there is a stalk over here, normal mucosa, and then there is a proliferation of the mucous glands. The classical feature is they are all well punched out, as though with a punching machine they have punched it out. And they are all lined by normal mucous glands. It can be goblet cells or columnar cells. I have also explained this picture in the game. Kindly go back to it. So it is an adenomatous polyp with tubules in the lamina propria. And juvenile polyp, it is multiple, usually occurs in the colon. As the name implicates, it occurs in children. There are large polyps over here. They also call it as hamartoma. Occurs predominantly in children less than 5 years of age. This is the supporting stroma or the lamina propria. These are all the glands of varying sizes, absolutely blunt. Tubulovillous. Earlier we had seen tubule, well punched out glands, but in this I am finding that there are some glands which we can still call as tubular, but then there are multiple finger-like projections which are the villi. So it is a tubulovillous adenoma. Generally the criteria is 25 to 75% should be villous, and it is an intermediate form. The behavior is in between an adenocarcinoma, tubular adenoma, and a villous adenoma. This again, going back to it, a couple of pictures for the nature of the polyp. It can be a hyperplastic polyp or it can be an adenomatous polyp. And it can be either a pedunculated polyp that we are seeing or it can be a sessile polyp. And this is a diagram of a hyperplastic polyp, almost a hamartoma. Projections are there, but main thing to concentrate is the serrated lumen that we are seeing. This is a tabular column that you people should leisurely by heart. It gives a summary of the entire gamut of changes that you see in the polyps. The range of polyps are given over here. What is the site, morphology, the microscopy, and the significance. Is it clear? For example, a villous adenoma, you find that there is 40% malignant risk, whereas in a tubular adenoma, it is much less, depending on the size. Juvenile polyp more commonly seen in the children. I would like you people to kindly by heart this one. I will not be repeating it because it has been covered elsewhere. Gardner's syndrome. Always a syndrome is a group of disorders that are packed together. So in this, the patient can be having multiple impacted supernumerary teeth. It is an adult patient, but then you find that no tooth has fallen. It is retained, and there are also the new teeth. It results in supernumerary teeth. Multiple polyps can be seen in the intestine. Osteoma of the bone, a benign tumor of the bone, multiple epidermal cysts, and there can be desmoid tumors also. Desmoid tumors are fibrocollagenous. So kindly read this one. Gardner syndrome, if you write, you score a mark over it. Turcot syndrome is another one. Polyp will be there. There will be a medulloblastoma and a glioblastoma multiforme. This is a brain tumor called as glioblastoma multiforme. And there is a congenital hypertrophy of the pigmented epithelium of the retina. So this is called as CHRP, CHRPE. As mentioned earlier, these polyps can be associated with carcinoma or elsewhere. A carcinoma colon can also coexist with a Turcot syndrome. This is the sequence of events that happens in the development of a polyp. Initially, there is a small hyperplasia, then it becomes a small polyp, and you find it is adenomatous initially. Part of it is becoming dysplastic or grayish in color. There is no invasion, but here there is an invasion. It goes into the fibrovascular stroma, and in this particular case, it is infiltrating the muscular layer of frank malignancy. And we had mentioned earlier that there are numerous genes for it. This particular diagram we had seen in colorectal carcinoma, and it is a must that we will have to draw it. This shows an invasive carcinoma. The rest of it is a tubular lesion, the stalk. And what does this picture implicate? I think it is a mistake, or you will have to mention the genes that are associated with it. It can be the APC gene or the P53 gene or the DCC, etc. All have been covered in this. And this is a case of a polyp. You have got the solitary polyp as well as multiple polyps, and this is again given for description. The normal mucosa, and then this is the polypoid lesion. Here I have got multiple polyps. Obviously, you are seeing a difference. This is appearing more bland, this is small, whereas here I am finding a little bit of friability into a malignant transformation. Stages of dysplasia, we have already mentioned. It can be confined to the glands, or it can be gradually extending into the fibrovascular core, or it can be frankly invading. And this is a villous adenoma, which is again showing it. Please draw this. And sometimes you find carcinoma itself can occur as a polyp. So it is a lesion that is large, ulceroproliferative, with evidence of necrosis. And this has been covered in the colorectal cancer. I would like you people to go back to it. ZZ. Thank you.